Your first discussion from me anyway is going to be ATLS. Anybody excited about taking ATLS courses? Based on the laughter, I will say no. Have you guys taken one the last couple of years? Well, you know, I think some of the issues are with ATLS is that it really was focused for those people who had absolutely no freaking business doing in an emergency department. They shouldn't have been there at all. They shouldn't have been practicing emergency medicine. Well, things have changed quite a bit. You look back in, I think it was 1978 when this was all started. I don't know the details. You guys can probably fill in the holes, but I think it was an orthopedist flying his private plane. That's already a problem. Put his family in there and crashed, I think, in Nebraska in a cornfield. And so nobody did very well, and they brought him to the local hospital, and it was like an oral surgeon working or something like, man, the teeth look great, but I don't know what to do about this femur fracture, and I don't know how to manage the airway. So they came up with ATLS, been teaching it in 50 countries and trying to really improve the standard of trauma resuscitation. The problem is they never factored in that emergency medicine would really be a true specialty, have good training and board certification. And it's been a frustration a little bit, just a small portion to all of us when we have to take those courses. Now, do you take them because you want to or because you have to? You want to? That's good. I think there's some good education there. What I found with our group is most of the time when our docs take it, it's because they have to. Either mandated for credentialing from the hospital or mandated from credentialing from a third-party payer. And I will tell you, if you don't want to do that anymore, if you really go to them, you can really get that changed. With most of our sites and most of our third-party payer contracts, we've gotten those merit badge course requirements removed. For docs or board certified, particularly if they're residency trained in emergency medicine, we let them know that probably a day and a half spent with a surgeon is not necessarily going to impact our practice. It's not going to happen. And remember, if you look at the preamble inside the old ATLS manual, what was it based on? The preamble for the surgeon is frequently wrong, never in doubt. Is that right? So that's the way they based this whole manual. And they said, if we think it's right, it is right, and this is the way you should do it. There will be a finger in every rectum. There will be a tube in every penis and every nose. Does it make any sense? No, it was a lot of dogma. And that dogma doesn't make sense. The good news is they heard the message, at least partially. And now the 8th revision that came out October of 07 really started to add some evidence-based information to the recommendations that they have. Now, a lot of these things that we'll talk about, they're behind us anyway with what we're doing in practice. But specifically, the resuscitation areas and the surgical areas, I think they really are giving us some good information that we can really work with. All right, so let's talk about a few things they have changed. What about CO2 detectors? Are we all using end-tidal CO2 detectors? Good, okay. For airway management and confirming tubes, that's a very valuable thing. It's a standard of care. Now, they said they kind of commented they thought they knew what one was in the 7th edition, but the 8th edition, they've gone one step further. They said, let's go beyond capnometry, which is the little devices, a one-time thing, fine, it's in, the tube is in the right place. We have colorimetric change, let's move on. And they said now, which is very reasonable, that it's state-of-the-art and it's ideal to use capnography. And I want to tell you also, a little beyond the scope of this talk, but we need to get capnography in our departments because with moderate sedation as well as with airway management, we're really going to be required to do this in the future. Let's monitor it on a graph on a regular basis. If we're having a problem and a significant change, we'll know that maybe the airway's been dislodged or it's plugged or whatever's going on, as opposed to waiting for some other problem with the patient, such as a total decompensation. You look at abstract number 1, basically it just confirms what we've said. That came out of Medical Clinics North America, November 2008, and said really we should be using capnography. So if you're going to spend some money for capital funds at your department this year, that's one place to go. All right, how about LMAs? They've recognized LMAs in the manual now as a good airway management device. Everybody have an LMA in their difficult airway cart? Good. Lots of sizes. Using the standard LMA or the intubating LMA? A couple of both, maybe. You guys still tired? You guys aren't local, are you? It was like a 13-hour trip for me coming in yesterday, too. But amazing. When I took the bus in, everybody takes the bus, right? Nobody rents a car, flies in by helicopter or anything? Yes, sir.
I rented a car.
You rented a car?
That was a mistake.
Man, I took my kids, flew through customs, immigration, everything, and we got the early bus. Flight gets in late at 11:30. We made the 12 o'clock bus. We just get past all those shops and everything out of town. Say, we're going to make an unscheduled stop. They stop because they're going to wait for 3 people to join us. This is unprecedented. We've never done it before. And my kid's like, I'm hungry. I have to pee. And I'm like, you know, I did a Forrest Gump and I ran to a Subway. The guy's like, wait, the bus is going to leave. I said, I'll be back. And I just ran around the corner, came back about 20 minutes later with sandwiches. I did offer for the other people, but they didn't think I was coming back or something. Nobody wanted me to get them anything. But it worked out pretty well. But the bus ride, that's amazing. If they ever stop, take your chance, get something to drink and something to eat. All right, so anyway, LMA is great. Get the intubating LMA, you can intubate right through it. If you're able to ventilate, you can go ahead and most likely intubate right through it. How about the laryngeal tube airway? They commented about this as well. We know it as the combat tube. Does everyone have one of these in their difficult airway cart? Good thing to have. It's not sexy. You certainly wouldn't do the typical airway dance when you get a difficult airway and you put the endotracheal tube in. You're not going to go to your anesthesia colleagues and say, yeah, put a pretty good combat tube in the other day. It's not what you're going to want to brag about. What's nice is it's a blind insertion. And if that thing goes in the esophagus, well, you just inflate both cuffs and the air is diverted right down into the trachea. If it goes in the trachea, well, then all you have to do is inflate the pharyngeal balloon and it's going to go right down into the trachea. So it works as a temporizing device. And so it's good to have around if you get into real trouble. All right, they talk about gum elastic bougies or the Eschmann catheter. Have you guys ever used one of these? You guys like them? I mean, this is the first time they're really commenting about these. But I tell you, they were around when I was training at Charity New Orleans. We all had one. And it was, I mean, I graduated from there in '96. This is not new information. The American College of Surgeons just picked up on this. But the problem I always had with it is you can't really, they're not disposable and you have to have them cleaned. You just can't reuse them right after one patient to the next. And every time we would send it to get autoclaved or cleaned or sterilized, whatever they do with it, anesthesia got a new one because they would package it and send it back to anesthesia. We would never get our Eschmann back. What's nice about the Eschmann, it kind of gave us a sense of where we need to go. And what's really better is the Cook intubating catheter. Does everyone have one of these in your difficult airway cart? If you do not, you should have one. This combines the Eschmann technology with an open tube so that you can ventilate through it, you can suction through it, and it works very well. It works very well. Remember, with the Eschmann or with the Cook intubating catheter, you load your endotracheal tube right on it and you can thread it right off. Lots of times you can visualize an airway, but it's so anterior, well, it's up there, I just can't get the tube directed there. That's where these are helpful. You can put these devices right through the cords and then thread the tube right off. Usually, my experience has been a clockwise turn of about 45 to 60 degrees right as you enter the cords will stop the bevel from catching right on the cords. It's just, remember, you've got another tube in place with the Eschmann or the Cook intubating catheter. So if you rotate it around, it'll generally go right in. All right, as far as difficult airway goes, they've said now they've recognized the possibility that we may run into a difficult airway, and they understand the problems with that. They recommend a mnemonic, lemon, look, evaluate, get your Malin-Patty score, and take a look for obstruction and look at the neck. So basically look at your patient and say, am I going to run into trouble here or not? We're good at it. I guess they're just starting to get used to the concept. But remember, surgeons have what kind of buddies hanging around all the time? Yeah, they never travel without an anesthesiologist. So they never dealt with significant airway issues in the ATLS manual. All right, abstract number 2, we can take a look at that for a minute or two. It's talking about airway type of maneuvers. Do you guys like cricoid pressure? Cricoid pressure isn't bad. If you look at the data here, we've got a lot of abstracts to go through, so we'll just talk about abstracts 2 and 3 in aggregate here. Cricoid pressure oftentimes will actually worsen visualization. That's what can happen with it. It does help to compress the esophagus so that when you are doing RSI, you limit the risk of aspiration. But you have to be careful. If you can't visualize, the first thing you want to do is have that respiratory therapist, whoever's doing cricoid pressure, let go, and you're likely to see it. How about the burp maneuver? Not after a case of beer. With airway management we're talking about. Burp maneuver. Have you guys done that? Backward, upward, rightward pressure. And that was touted as, hey, this is a great thing. This will work out great, help you to visualize. Well, it's been somewhat refuted as well, and you can't really do it by yourself. You've got to have someone do that unless you want to be able to have someone find the right position and then be able to pick up your tube while they hold that position. And that's moving into the next phase of things called bimanual laryngoscopy. And I've tried this recently after I read a couple of these abstracts, and it really works. Have you guys tried this? What bimanual laryngoscopy is, get rid of burp. Cricoid pressure is probably not that necessary unless we're worried about aspiration. And what you do is you use the laryngoscope with your left hand like normal. With the right hand, you reach around the thyroid cartilage and you move the airway around until you can see the airway best. Then you have your assistant come in and say, hold this position. Now you pick up your tube and intubate them. So if you're having trouble visualizing the airway, use bimanual laryngoscopy and you'll have a lot better success. and it's very helpful. All right. Just when you get a chance, you might want to take a look at the details in Abstract 3. It really does show that when you use the burp maneuver, you're more likely to significantly worsen visualization. And you can look at some of the details and some of the data on that. All right. What are the substantial changes for resuscitation and hemorrhage control? Well, crystalloids. What did they say about those? For surgeons, it was always Ringer's lactate, right? What amazes me is Ringer's lactate is an isotonic solution. It's a hypotonic solution where normal saline is really the only true isotonic solution. Why are we resuscitating patients with a hypotonic solution? It doesn't make sense to me, but that's what they always said. Now they've stated, well, maybe saline's a reasonable choice. And particularly if you're going to give blood products, you can't give blood products through lactated Ringers. You should not admix them that way. It should be in saline. So maybe we should really be using warm saline. Another concept they talked about is hypertonic saline. Anyone using hypertonic saline to resuscitate their patients from volume loss? A couple hands. Where the big benefit has been reported, or at least hypothesized or theorized, is when someone is hypotensive, but they also have a brain injury. So you want to be able to resuscitate them from a hemodynamic standpoint, but reduce the risk of cerebral edema. And that's what they talk about, and that's where we're really at with abstracts 4, 5, and 6. Well, those abstracts, they talk about, well, will it really help? And theoretically, I guess it's kind of like bicarb. Theoretically, it makes sense it would work, but when you finally study it, it doesn't work the way we think it would. What we know will happen when you use hypertonic saline is we know that sodium and the chloride will go up, that's for sure. And we also know, though, that cerebral edema doesn't really change from one group to the next, and neither does the resuscitative outcome. So it really doesn't help. You could use it, and maybe more data will come out, but it really hasn't been proven to be beneficial. All right, fluid resuscitation overall, if you look at abstracts 7, 8, and 9, they're talking about hemorrhage control and the concept of balanced resuscitation, controlled resuscitation, permissive hypotension, those type of things. And that really came from Maddox, I think, back in the 90s, I think in 94, when he reported that maybe we are over-aggressively resuscitating our trauma patients. And maybe we are forcing more blood loss as opposed to really improving them. Particularly go to abstract 9, that's from 94, they said maybe the concept of trying to normalize a blood pressure in trauma isn't a good one and needs to be reassessed. And that's what they've done in 7 and 8. They've taken a look at it. In 7 is a little bit questionable. It was a Cochrane database review, and they said, well, we kind of like the idea, but there's really no definitive information to say that we really should delay resuscitation or that we should do full resuscitation as we had before. They kind of stayed right in the middle, and they stayed on the fence. But I really like abstract number 8. If you take a look at this, they limited the amount of pre-hospital fluid and the amount of ED fluid as well. They had 309 patients in the immediate fluid resuscitation wing or arm of this. They got 870 cc's of Ringer's lactate in the pre-hospital setting, 1,608 cc's in the trauma center. 289 were in the delayed resuscitation group. And these patients were limited to 10 cc's an hour, got 92 cc's in the field, 283 in the trauma center. What was interesting is the people who had delayed resuscitation had lower blood pressures. Are we surprised? No, we didn't resuscitate them as much. Who had a higher hemoglobin, though? We may have used a blood pressure as a surrogate marker in the past as improvement. Actually, the hemoglobins were better for those who had delayed resuscitation, implying that they're losing less blood because we're not forcing it out with a higher systolic pressure. So abstract 8 is very important, and I would say that we need to really consider the concept of delayed resuscitation. You get that patient's blood pressure to 90 or 100, maybe you need to just sit tight at that point. They're talking about blood pressures here in the 70s. I don't know that we want to go that far at this point. But a blood pressure of 180 over 90, and we're given liter after liter of fluid, and we have somebody who does not have controlled hemorrhage, that's a problem. All right, angio embolization for definitive hemorrhage control. We're talking basically about pelvic fractures. If you have a patient with a pelvic fracture and they are hemodynamically unresponsive to resuscitative efforts, they're getting hypotensive or they're staying hypotensive, and they have a pelvic fracture, you need a surgeon, and they may need to have angiography with embolization. And ATLS has said now that is the way to go if you've tried to resuscitate them and it hasn't worked. If you look at abstract number 10, they had 32 hemodynamically unstable patients, 25 of them actually had angiographies and embolization. 24 were successful. So they went ahead and stopped the hemorrhage there. So you want to make sure, the key for us is I don't think we're going to actually perform that procedure, although that would be wicked cool, wouldn't it? That'd be kind of fun. Get me the angio cart. That'd be great. We're not going to do it, but we've got to make sure we know who does that for us and get those people on board as soon as we can. Interesting change with pericardial tamponade, and this is a big move, a different direction. You know, in the 7th edition of the ATLS manual, they said, you know, pericardiocentesis is the way to go. Now they've said that's a temporizing measure if and only if you cannot do an ED resuscitative thoracotomy. If you have tamponade, they're saying go right to thoracotomy, which is a big departure, and it probably makes a lot of sense. You have somebody circling the drain, their pressure's 80, now it's 60, now it's 40, and you're putting chest tubes in and doing a pericardiocentesis. Hey, we can do all that in one shot. We can decompress the lungs, we can decompress the pericardium, we just have to use a bigger tool, and we do it all at once. All right, pneumothorax. If you look at the 8th edition, finally, the dogma that every traumatic chest tube must have a chest tube placed is gone. We do not have to do that anymore. And I think finally a surgeon somewhere actually had a chest tube placed on them. And that is a nasty procedure. And we've seen, this is where they're lagging behind us quite a bit. We're looking at these patients saying, you know what, they're doing great. I'm going to throw them on 100% O2 by a non-rebreather, and I'm just going to watch them. I am not putting a chest tube in this person with a small pneumothorax. And if you look at abstract number 11, it's interesting. I'll save you the details, but I'll give you the take-home message. All these mathematical parameters and calculations and visual inspections of chest x-rays have never been validated and cannot estimate the percentage of a pneumothorax. You, I suppose, are allowed to say, wow, that looks like a small one, or wow, that's a really big one. That's as far as it goes. You can't say, well, I think this one's about 12.65%. It just doesn't work that way. And so you have to be a little bit careful with that. But what ATLS has agreed to is that, yes, you can observe some pneumothoraces, small ones, that appear to be small, if they're doing fine. You can also use aspiration. Anyone done aspiration of a pneumothorax? Without even putting a device in, not even talking about a small caliber tube or using a Heimlich valve. You can just put a needle in there, 16 or 18 gauge needle, aspirate the air. Some of these articles have even talked about pulling out as much as 3 liters. I think that's in the realm of a tension pneumothorax. And keep pulling the air out. I think they're getting better. That's probably not the right way to go for that type of person. But you can certainly do that, and it's very effective. And the take-home message with aspiration or even with a small caliber device is, what if it fails? Okay, now you get a chest tube. You were going to get one of those potentially anyway. So this is a great first step. Now, the American College of Surgeons really couldn't get away from keeping control of things. They said it has to be a qualified person. They don't really say who that is. I am going to venture to guess that they don't mean an emergency physician. They probably mean a cardiothoracic surgeon at an Ivy League institution. You probably have to consult them, I don't know, by teleradiography or something. I have no idea. But they say it has to be a qualified person making that decision. So you can definitely do this. You can aspirate, you can use small catheter devices, you can use a Heimlich valve. If they're doing well, I believe it was, which abstract here? We can go right to it. 12 talked about small catheter devices versus closed thoracotomy. Remember, 11 patients had complications with the closed thoracostomy. They had a chest tube put in, 11 complications. Aspiration and small caliber devices, such as in that abstract number 12, no complications at all. It's worth a try. It's worth a try. And they also discussed here that if you're doing well, you have 3 to 6 hours worth of observation, and you show no signs of worsening either clinically or radiographically, you can be observed as an outpatient. And yes, even if that's a traumatic pneumothorax. All right, let's talk about ED thoracotomy. Anybody done one of those this week? Nope. The last 6 months? Nice work. Did it work? No. Why are we not surprised? Yeah. This procedure is on its way out the door. It's pretty cool, though. I mean, how about in the last year? Okay, more hands are going up. Great. Anybody have a successful one? Yeah, that's, oh, great. Tell us what happened.
Lots of them. I was in a referee.
Okay, great.
Lots of them cash at the aid station where we were. We flew with the patients. But we started doing it with a higher, we didn't wait till they were dead.
Perfect.
We started doing, we determined that they had a traumatic penetrating chest.
Mm-hmm.
We would do them earlier and earlier.
Great point. He said he was in Iraq, did several of them, but they were successful because they did them when they began to decompensate, and that's the key. If you can catch them there, that's the point I was making earlier. That's not time for bilateral chest tubes and a pericardiocentesis. You have a very narrow window of opportunity. That's the time to strap some on and get the big equipment and do the thoracotomy. That's when you're going to help somebody. And so I'm glad you had the experience to do that. What they're saying here now is the opportunity for benefit here is very, very limited. It's very limited. But you can still do it. If it's blunt trauma and they present to the ED without pulses, it doesn't matter what's on the monitor, you're done there. If it's penetrating trauma and they present to the ED without pulses but they still have electrical activity, they would recommend you go ahead and move forward with this. Some of the literature that's out there doesn't exactly agree with their approach, and we'll talk about that. Most of it does, but some of it does not. Abstract 15 talks about ED thoracotomy actually with abdominal trauma, penetrating abdominal trauma, and they had some pretty reasonable results there. Basically, they looked at a chart review of 50 patients. EMS time was 21 minutes. All the 8 patients who survived to discharge had normal neurologic function when they left. So even with abdominal trauma, you could consider that if you have to get proximal control. And 7 of the 8 survivors actually were transported by police or private vehicle. And we know what that's telling us also. We aren't talking about it here, but there's some recent literature that's come out as well that the stay and play concept with EMS, with advanced life support, is not a good one. It's not that ALS isn't good, but if you waste time on the scene to implement that, that's a bad thing. And that's kind of what this is speaking to also. Throw them in the back of a police car, they will do better if they need a thoracotomy than if you're doing a bunch of other things like establishing multiple IVs in the field. All right, abstract 16. They looked at a 26-year study, 959 patients, 62 patients who survived, and 42% required prehospital CPR. The reason this abstract is here is so just you realize that those who do end up getting resuscitated frequently have had a cardiac arrest and had CPR performed in the field. So don't just say, they're already pulseless, there's no benefit. There is some benefit if you're going to do this at all. And what they recommended as well is if it's penetrating trauma, you can move out to 15 minutes based on this data saying, wait, there could still be a chance. So those who love to do the thoracotomy, you would cite this article and say, I got up to 15 minutes, and I can do this. 15 minutes of CPR. All right, let's move on to hemodynamically unstable pelvic fractures. Same concept, angio embolization is the way we want to go, but they also talk about, for us, doing some sort of compressive stabilizing maneuver. Whether you tie sheets together, this is the one and only last final use of a mast trousers. Anyone have any mast trousers? Anybody wearing any to ski in? They're warm. You bounce, it may work, but not great for flexibility at all. So, but if you have them around, they are great to stabilize a pelvic fracture. And you can do that and minimize blood loss by employing one of those things. All right, what changes are recommended for CNS system injuries? Well, let's talk about minor head injury first, and we won't go into this in great detail, but remember, minor head injury does not mean minor brain injury. It means minor mechanism, something that we didn't think would precipitate a significant traumatic brain injury. And looking at abstracts 17 and 18, they really quoted the Canadian CT head rule, and taking a look at who's at risk. The Glasgow Coma scale of 14 to 15 is mild brain injury. 13 to 15 is defined as maybe moderate, and then 9 to 12 is really significant or severe brain injury. Is it hard for us to decide who we're going to CAT scan when you've got a Glasgow Coma scale of 5? It's easy. But when that person has a Glasgow in between 13 and 15, we may be making the wrong decision. What's nice about head injury is it's only one decision. Are we scanning them or are we not scanning them? You can go the direction of scanning everybody, but it's overkill. But at least in the US, with our medical legal system, if you don't scan the right ones and you miss an intracranial injury, they're not going to say, yeah, but look how much money he saved or she saved without ordering all those other unnecessary tests. They just don't care. It's the one that you missed that they're worried about. And although the Canadian CT head rule is good, it talks about 5 risk factors. Glasgow less than 15 within 2 hours of injury, suspected open or depressed skull fracture, signs of basilar skull fracture, vomiting of 2 or more episodes, not just nausea, not vomiting once, and age greater than 65. Well, if you have any of those, you need to get scanned. And if you employed that, you would save the amount of CTs by 32%. What I don't like about these 2 decision rules, New Orleans as well as the Canadian head CT rule, is they're telling us when we don't need to do a test, not how can we better find the right people. Now, both of these in abstract 17 and 18, they were able to get 100% of the 8 people that they identified needed neurosurgical intervention. But what's the one loophole that I don't like with the Canadian CT head rule is they're willing to accept 4% of patients who have clinically insignificant intracranial injuries. Well, I'd like to know what they mean by clinically insignificant. When I work, I want to know every intracranial injury that I have. Maybe it's going to be inconsequential down the road, but again, with our medical legal system, that's still a miss. And a miss somehow, instead of being the fry guy at Wendy's, they could have gone to Harvard, but because you missed that small intraparenchymal injury, that contusion, things have changed. So you want to make sure that you identify them. You have to make a decision of whether you're comfortable missing those 4%. I'm not. All right, penetrating brain trauma. This is not a new concept, but I want to really emphasize this. Don't take sharp objects out of someone's brain. Leave them there. There's a neurosurgeon that will take care of that. You know, did someone lose this knife? I mean, don't grab that. Leave it there, dress it, whatever you need to, get the neurosurgeon. A newer concept that's really worthy of our consideration is blunt carotid and vertebral artery dissections. If you look at who's really at risk, C1 to 3 fractures, C-spine fractures with subluxation, and those who have fractures involving the foramen transversarium. If you are concerned there's significant neck trauma, you need to consider this. Only about 1% of trauma patients have these, but if you miss this, there will be a bad outcome. Bad things will happen. And if you have somebody with significant head injury, you need to be considering the possibility. You look at abstract number 19, it said 2% of all ischemic strokes are caused by dissections, not necessarily traumatic ones, but if you look at the age group under 45, it's 20% of all strokes. Something we need to be thinking about. You have a trauma patient, you have a neck injury with new onset of neurologic symptoms, you need to be thinking about this and need to go to angiography. What's nice about this, at least specifically for the vertebral ones, is at 6 months, 90% are going to heal. Remember, these are not treated with a surgical approach. These are anticoagulated. And there are two mechanisms for injury to the brain. It's either decreased cerebral blood flow, or it's just due to ischemia, or it's due to thromboembolic phenomena. Overall, the majority of these are thromboembolic phenomena at the site of the dissection. All right. How about steroids? Steroids in non-penetrating spinal cord injury. Are we using steroids, high-dose methylprednisolone? Nope, we aren't. Good. Well, that's gone back and forth, and still the plaintiff's attorneys have been behind us a little bit, and they're still clinging to that as a false standard of care. But what's great about this now, this has really helped us. We've known the data. The data has suggested for years that the initial data that came out was flawed, and it had all kinds of problems with it, and there's really no true benefit to this clinically. But now, with the 8th edition of ATLS coming out and saying there's no proven benefit, now you can stand up and say, I have a clinical guideline from the American College of Surgeons that said this is not of benefit to these patients. That is huge from a risk management and a defense standpoint. Very big. All right, if you want to look at, we're running a little close on time, so abstracts 20 through 24 will go through that history and tell you about the articles that are out there. But I'm here to tell you, some of them will report minimal benefit or marginal benefit, but there's significant flaw with those studies. And if you reflect back to the National Acute Spinal Cord Injury Study, the first one that came out, that was in vogue for probably 10 years or more, and people were relying on it, and it really is not a benefit. All right, CT of the cervical spine. Should that really replace plain radiographs? What do you guys think? Well, it depends. If you're a kind of a tree-hugging person and don't like radiation exposure, then you're going to stick with the plain radiographs. If you really want to make sure that you're ordering the right test to find the right pathology, CT is by far a better test. And hopefully they can bring the cost down to it. Why are we not missing a whole lot of C-spine fractures when we order plain films? Why is it an acceptable practice? Anyone have an idea or thought on that? My thought on this is when we select out a very, very low prevalence, low incidence population, the patient that comes in, I have a little bit of neck pain, I was in a fender bender, and we're like, well, by Nexus or by the Canadian C-spine rules, I can't clear you, I'm going to order some films. You already know they're negative, right? Your pretest probability is almost zero. So we can keep ordering a bad test and it's going to work great for us when we know the patient doesn't have the disease. That's why plain radiographs work fine. But if you are moderately suspicious or you're significantly suspicious, you need to go right to CT. And if they're going to CT for some other reason, why don't you just CT the C-spine if you have to image the C-spine anyway? If they're going for a CT scan of the brain anyway, just go ahead and get the C-spine. And it makes perfect sense. As far as radiation exposure goes, if they're above age 50, That is free radiation. There is no time left, unfortunately, to develop a leukemia or a solid organ cancer from the radiation exposure we're going to provide medically. So go ahead, scan them all you want. The younger people who we're worried about, if you look at some of these abstracts, 25 through 29, we're worried really about the kids. That's jumping down to 29. The radiation exposure is significant. And this is when I think you have to have a conversation with the parents, and this is a great place for informed consent or informed refusal. Because we know that, average radiation exposure in Japan in the 1940s with atomic bomb blasts was about 45 millisieverts. Well, we know with the infant brain, it's about 95 millisieverts right to the brain. We don't know what this means for sure, but we don't think it means anything good. And there's never going to be a randomized controlled study to say how much radiation exposure you get and see if you develop a cancer. First of all, the downside is too great for a free ticket to a movie or something. People aren't going to sign up for that one. And also, the cohort would have to be followed for so long, we're never going to get to do that. So there's a significant concern. We just have to be careful with this. So be careful with radiation exposure in kids. And as far as sensitivities, I want to mention to you, a couple of these abstracts are very important. If you look at 25, sensitivity of plain radiographs for C-spine fracture, 52%, CT is 98%. That has been duplicated over and over and over again. And there are a couple other abstracts here talk about that as well. But I want you to know those numbers because the test is not great, but we're applying it to a patient population who normally we don't really expect to have the disease, so we're okay there. Atlanto-occipital dislocation, I won't go into the calculation, but they talk about cervical dynamic screening and spinal clearance doesn't help. You don't need flexion extension views, anything like that. But they do talk about the powers ratio, and that's really for radiology to make this calculation about the distances at the base of the skull and see what's happening there and see if there's an atlanto-occipital dislocation. And so I'm really surprised ATLS actually mentioned it, but they did. So you should get radiology involved with that one. All right, what other changes? Some random changes they made. How about rectal examinations? I'll tell you, when I trained, we had so many trauma resuscitations at Charity every day, we got assigned one job every day. And do you want to be the chest tube person? Yeah. Do you want to be the airway guy? Yeah. Okay, who's going to be the rectal Foley guy today? It was always the same person because you had to do the rectal first before you could put the Foley in. Well, no, it was always the last person standing. And sure enough, they got the rectal Foley job. Well, do you have to do that before? Do you have to do a rectal examination before putting a Foley in? No, you don't. That's dogma. Do people look at you like you have a third eye in the middle of your forehead when you say, just go ahead and put the Foley in? But doctor, you haven't put your finger in their rectum yet. Yeah, I know that. And I can tell based on examining their pelvis, and there's no blood at the urethral meatus, that they don't have a disruption of the urethra or the bladder. I can tell that by examining them. And if you look at these abstracts, if you look at 31, and you look at 32 as well, and 33, it's telling you the same thing. That basically, you're going to clinically know who's at risk for these things, then you do your rectal examination. And some of these abstracts cite as well, even when you do that, it may not be great. It may not help you identify all the people you need to. Spinal cord injuries, is it a great test for spinal cord injury? Sir, you may be paralyzed. Beyond that, I'm going to put a finger in your rectum. I mean, that's not a great thing either. And actually, it misses about 50 to 60% of those people. One thing I do want to mention to you as well is kind of interesting, abstract 31. It said, after a minor motor vehicle accident, normal sphincterotomas facilitated a diagnosis of malingering. So that's a great reason to use a rectal examination. I got a great story. I know we're running short on time. I got to tell you the story. I had a friend who was an oral surgery resident at Charity. His name was Andy Chang. Like a sumo-looking guy, huge guy, 6'5", huge. And I had this guy from jail that rolled out of the top bunk. I can't move anything. I've got him in the radiology suite. At that point, we're doing flexion extension, we're doing all kinds of stuff. And I said, you know what? I'm going to do the rectal examination. He didn't move at all. And I just really suspected that he just wanted a vacation. And Andy was walking by after doing a procedure or something. I said, Andy, come in here a second. And I talked to this guy. I don't remember his name. I said, dude, take a look at Andy. Andy, hold up your hand. I said, if you don't get up and walk out of this radiology suite, he's doing the next rectal examination. I swear to you, he got up and walked. Here are your discharge papers. It was done. So what's nice is that's actually an acceptable practice in abstract 31. You want to use a rectal examination to incite a neural response. That's a great thing. Okay, tourniquets in extremity trauma. They have to mention it. It's ATLS. Only use it. Only use it if you absolutely have no other way to control hemorrhage loss, blood loss in an extremity. And you've got to let the patient know. This is one thing new. You've got to tell them, when I do this, you may lose the extremity, and that's important. All right, what else do we have here? Explosive devices, not worth talking about. There's a small amount of information. They just recognize the injuries that could happen from that. Trauma and pregnancy. They basically state that airbag deployment does not appear to be associated with increased injury, which is important to note. Pediatric trauma, the splenic blush sign. If you infiltrated or they injected their contrast and there was a blush in the spleen, that was oftentimes a sign of an injury, and it still is. And they used to go to the OR. Now they're telling you in ATLS, and the abstracts here are supporting it, that you follow how they're doing hemodynamically and clinically. And if they're doing great, you observe those. They don't go right to the OR. Fast exam in pediatric abdominal pain or abdominal trauma, absolutely. Use the FAST, but it's not going to tell you who's necessarily going to the OR in pediatric patients. You're still going to observe them. You, again, follow the hemodynamics of the patient and how well they're doing. It is important to know that the blood is there, important to know who's going to go to CT, but you're going to stop short there in the stable pediatric patients. And then the seatbelt sign, the last piece of information. Is the seatbelt sign helpful for us? If you see in abdominal trauma, ecchymosis across the abdomen from the seatbelt, is there an increased risk of injury there? Yeah, it's pretty substantial. So at that point, you know, you're ordering a CT, you're likely going to find something, you're likely going to have to call the surgeon at that point. Let me see, abstract 38, if you take a look, 61 children with liver, abdominal or flank ecchymosis following motor vehicle accidents and use of adult safety belts. So that was definitely correlating there. Abdominal, pelvic, or lumbar spine injuries were ultimately diagnosed in 39 of the 61, so 64% compared to 28% of the intra-abdominal injuries in the remaining 90%. So it was important, and these were verified by CT. If you've got a seatbelt sign, you're probably going to consult the surgeon, and you got to get the CT. Looks like we're out of time, guys, so thanks for your help and thanks for your time, and I will see you a little bit later.